the left atrial appendage through the transesophageal approach, generally we evaluate in the upper esophageal at the 0-degree view. So if I analyze this picture, the left atrium to left atrial appendage generally is straight unless and until it is cactus or the chicken wing, and it is closer to the left upper pulmonary vein. So it is always easier to put your seed or wire first in the left upper pulmonary vein, then drop it down to the left atrium. You may inject a few amount of contrast media to confirm your position, whether it is in the left upper pulmonary vein or in the left atrial appendage. Then definitely wiring is important, and gradual progression of the seed to the left atrial appendage up to 10 to 12 millimeter advancement, because the placement of the left atrial, whether it is the Amplager plug or the Watchman device, the length assessment is important where I should release the device. Because to release the device, it is generally recommended that 10 to 12 millimeter gap from the ostium, that means the LA ridge to the left atrial appendage, is generally necessary. And it is close to two things. Number one, the LCX artery and the left upper pulmonary vein. So we have to take care of these two things. The 4-chamber approach in the transesophageal approach is absolutely necessary to measure the height of the puncture, because generally it is done within the 2 to 2.5 millimeter of the crux. That means the mitral or tricuspid crux anatomy. If I go higher, then I may be able to reach the wire, but the seed will be kinked. And when I push the device, be it a Watchman, be it an Amplager, then suppose it may be impinged into the lobe, but it may not be retracted again. So this kind of situations may not close the left atrial appendage properly. So the absolute height where the left interatrial septum is to be punctured is necessary, and it is to be done within 2 to 2.5 centimeter from the cracks. If we put it higher, it may be we may not be comfortable to reach the left atrial appendage. If we do it lower, it may hinge in the other pulmonary veins also. So another view, starting from the 90 to 0 degree to 120 to 135 in the mid-esophageal approach, generally gives us the right data of the left atrial appendage anatomy, whether it is chicken wing, whether it is cactus, or whether the some other anatomies, and the lobe is important, because I have put a Amplager device in a small lobe and there is another large lobe sitting in beside, it may not be occluded properly. So the lobe evaluation as well as the anatomy evaluation is important, and this is to be done in the 120 to 135 degree mid-esophageal approach. Now, coming back again to the interatrial septum, generally the puncture is done in the bicaval view. We all are familiar with the bicaval view. It is a mid-esophageal 90 degree with a slight right turn. It is being done. In the bicaval view, generally we can see the IVC and SBC simultaneously with both the atrium, starting from the left atrium to the right atrium. And in the bicaval view as well as the 0 degree and the 45 degree view, we can evaluate where to puncture, and the indentation of that needle is generally easily visualized in the bicaval view. So the anteroposterior approach as well as the inferior superior approach is to be determined by these views. Now, the most important thing is the 0 degree and the 45 degree transesophageal view. In the 0 degree view, the left atrial appendage, the length from the left upper pulmonary vein can be evaluated, and generally it is released from the 10 to 12 millimeter until and unless the left atrial appendage is too large. If it is large, the length can be progressed to 10 to 15 millimeter also, and if it is carved in the ostium to the ridge, generally the length may be shorter also. So this 0 degree and 45 degree mid-esophageal evaluation is necessary to hinge to release the device and to measure the length of the disc to the device. Now, the most important views which I shall be discussing for the puncture, it is the bicaval view and the short axis view of the transesophageal approach. So in the bicaval view, we can easily delineate the superior as well as the inferior, that is the SBC and the IVC. And generally it is being done closer to the IVC, that is the inferior rim closer. And in the short axis view, it is done in the posterior part of that. So with these two views, generally for the left atrial appendage closure puncture, we do it in the inferior and the posterior part. Now, The length is important, the site is important, the height is important, and the most important thing is the anatomy of the left atrium and the closer proximity of the L6 artery as well as the left upper pulmonary vein. And the puncture, as I have already discussed, is generally done in the 5 or 6 o'clock position. If the right atrial anatomy is larger, if the right atrial is quite big, you may rotate your needle, broken bow needle to 6 or 7 o'clock position as well. So this is the slide which is showing that the optimal transeptal puncture sites of the left atrial appendage closer. The medial and posterior and the low transeptal puncture allows a straight approach to the left atrium. If we do it too high, the transeptal puncture more than 3.5 to 4 centimeter above the mitral valve plane.
Dr. Dutta, please sum up.
Yes, sure. So intracardiac echocardiography will help us in evaluating this kind of puncture as well. And the most important challenges we all should know that even if we puncture, we may not progress our sheath or the Mullin sheath because of the septal fibrosis, because of the lipomatous hypertrophy and these kind of situations. And in that case, we may use for advancement of the sheath, the coronary balloon or any other balloons you may use to progress the sheath if it is not crossing properly. Nowadays, the most important thing, the energy radio frequency transeptal kit is available, which is easier, which makes us easier to puncture as well as see the site of the puncture, as well as with the energy impulses, we can do it very easily without any damage to the nerve tissues. So this kind of recent advances in the septal puncture generally helps us to advance the guide wire also, and without injuring neither the left upper pulmonary vein or any other pulmonary vein or the left atrium, or there is minimal chances of causing tamponade as well. So the take-home message from today's topic is that transeptal puncture is absolutely necessary. Generally, TTE or transesophageal approach is necessary. Cardiac CT helps us in evaluating not only the lobes as well as the anatomy of the left atrial appendage. We must have experienced hands for septal puncture, but generally over the time and the recent advances have helped us. And these two views, that is bicaval view, transesophageal, and the mid-esophageal short axis view, helps us in evaluating the anatomy. CT-guided puncture may be to some extent needed, but generally echo is sufficient enough to reach our left atrial appendage, and the clot as well as the pericardial effusion before the procedure is the most two important things to be excluded. Thank you very much.
Thank you, Dr. Dutta. While choosing the amplager device or Watchman device, do you go for imaging in all cases, either CT or
no, not necessary. Not necessary, sir. Always not necessary. If I feel difficult in approaching the left atrial appendage, then I inject some kind of dyes like that. I have put a video also, sir. So generally after puncture, the needle straight away goes to the left upper pulmonary vein. It has to be dropped down again, and you can see the left atrial appendage. Then the wiring is being done, and you can slowly release the device. Once it's having an onion-like structure, the first lobe is released, then pull it back, and automatically the second flap is released. So it is easier if you are able to do all these things. So the anatomy evaluation is absolutely necessary, sir. And after the device placement, the one should exclude the damage of the left circumflex artery. So it is not recommended always, but it is safer to have a coronary angio done so that we are not damaging the circumflex artery or left upper pulmonary vein.
You mean angio after putting the device?
Yeah, I do angio after putting the device.
Thank you. Any question from the floor? Yeah, let me sit over. Thank you, Dr. Dutta, for your nice presentation. Thank you.
Thank you.
Thank you.